Good afternoon. My name is Joel Ario. I'm a managing director at Manat Health. Before this, I was an insurance commissioner in a couple of states. That's what got me involved with the AMA. I know how insurers should be covering services, and I know they don't always do a good job. And I found a great partner in the AMA in making the case that insurers need to do better with the opioid overdose issues. And so I've been working with them for 5 years now, and I have with me today two of the premier AMA leaders on these issues, Dr. Patrice Harris, who was the first director of the AMA Opioid Task Force, and then Dr. Bobby Mukkamala, who was the second director. I think the names changed maybe, Dr. Mukkamala, but the mission is still the same, to ensure that people who have these opioid issues as other substance use disorders get the kind of coverages that they deserve and need to get better. With that, I'll turn it to Dr. Harris to introduce herself.
Well, hello, and Joel, certainly it's good to be with you again. I am Dr. Patrice Harris. I'm a child and adolescent psychiatrist, and I'm a lot of formers. I'm the former chair of the board of the American Medical Association, former president of the former president of the American Medical Association, and former chair of the AMA Opioid Task Force. And it's certainly good also to be with my long-time friend and colleague, Dr. Bobby Mukkamala. It was not a difficult thing to move on from being chair of this group because I knew it was in great hands with Dr. Mukkamala.
And Dr. Mukkamala, do you want to introduce yourself?
Sure thing. Yep. Thanks, Joel. And hi again, Patrice. My name is Bobby Mukkamala. I'm an otolaryngologist here in Flint, Michigan, and continue to serve on the board of the American Medical Association. I'm immediate past chair of that board. And then, as Patrice mentioned, have taken the baton to chair the Substance Use Disorder and Pain Care Task Force of the AMA, continuing this work that Patrice started with her opioid task force, because the problem itself has changed, as we're going to talk about. And so it's an honor to continue the work that Patrice started, because there is more work to be done.
Well, as you can see, we have a great panel today, and let's just get right into it here. Dr. Harris, we'll start with you. When I first met you, you were president of the AMA, and you were also doing the opioid task force. What got the AMA to first create the task force?
Well, Joel, if you recall, in 2014, there was heightened awareness and conversation, appropriately so, about what we call then the opioid epidemic. But as we looked at this from the board level, we saw that there were a couple of glaring omissions, candidly. The focus was pretty narrow, and there was also a criminal justice focus when it came to solutions. So we at the AMA and at the Board of Trustees level wanted to make sure that we broadened the topic. We wanted to make sure that there was physician leadership on this issue, that there was a collaboration amongst the House of Medicine, if you would, state level, specialty society level. But we also wanted to focus on actions that physicians could take amongst ourselves, if you will, but also in partnership with other stakeholders. And so we decided at the board level to convene this task force, and Dr. Barbara McEnany, who was chair of the board at the time, appointed me as chair of the first opioid task force. And I will say that, as Bobby mentioned earlier, you can see that even the name has evolved, and that is appropriate because this epidemic has evolved.
So let's get into some of the specifics. We ended up focusing on 6 different policy areas. Can you kind of walk us through those policy areas and what kind of were the objectives in each of them and what's most important about them? Kind of just whatever color you want to add to how they are all being addressed by the task force and by our project.
Well, I'll start again with the fact that we on the task force wanted to make sure that we were holding ourselves accountable. And so let me start there. It was a last recommendation, but the recommendation was to monitor and evaluate programs. And again, plethora of laws passed, regulations passed at the time. Remember, we're going back to 2014 and 2015. But as we looked at those, again, they were narrowly focused. There wasn't a lot of evidence that informed those policies. They were focused just on physicians. And again, physicians had and still do have a role to play in solutions here. But it's important that we, and I've said this a lot of times, inspect what we expect. And so that sixth recommendation was to monitor and evaluate programs, because I think all of us have been aware of regulations, policies, laws that get passed, but no one ever goes back to say, are we meeting our metric? Are we meeting our objectives? And I have to say, oftentimes the objective is not really based on the patient and what's best on the patient, with the patient at the center. So monitor and evaluate programs, policies, laws was a key recommendation. And now I'll go back to the beginning. The first one was increase access to treatment. Certainly, we began the opioid epidemic, and now more appropriately named the overdose epidemic, with an already underfunded and under-resourced mental health system. And that included our system to treat those who have a substance use disorder. And so we came into this epidemic, if you will, with the dearth of treatment opportunities. And so we wanted to really focus on the importance of increasing access to treatment. And a little bit of color to that, as you say, Joel, it needed to be evidence-based treatment, right? As a psychiatrist, I know, and we've seen, all of us have seen, a lot of people hang out the proverbial shingle, if you will, and offer services that aren't evidence-based. And so we really wanted to highlight the importance of the need of increased access to treatment. And everyone's probably seen the slide where only 2 of 10 people who want medications for opioid use disorder, another evolution of the term, could get it at the time. That hasn't changed much in the last decade or so. So that was a critical recommendation. We also wanted to make sure that we had folks who were offering these treatment be trained and be physicians. A lot of barriers, and I'm sure both Bobby and I will get into this a little bit later, to physicians being able to offer this treatment in their offices, office-based treatment for an opioid use disorder. And so we wanted to highlight the barriers, and to our own community, though, the importance of physicians getting trained. And I'll let Bobby tell you his story there, but being trained as it is now, you have to go through some additional training. So we wanted to highlight the importance of that, and again, demonstrate physician leadership on that issue. Parity laws, we know, have been on the books since the George W. Bush administration, but no one's, again, gone back to inspect what we expect and enforce those parity laws. And so though they were on the books, many folks would go to seek treatment, calling up their provider, and realize that they weren't able to access that treatment in the same way that they would access treatment for a medical or a surgical need. Increase access to pain care. Listen, if we start from the beginning, and again, setting aside illicit and illegal motivations, people received opioids because they were in pain. And often it was the only opportunity, right? Because perhaps they needed or could have benefited from physical therapy. That wasn't covered in the same way, or they had higher copays. And then, of course, the other issues around the social determinants of health and getting transportation. So we wanted to make sure that comprehensive pain care was available, evidence-based, yes, but more than just sort of the one thing which people resorted to opioids, which, by the way, effective and appropriate treatment for pain in the right hands, but it is important to have more tools in our toolbox. And next is harm reduction. Coming from my lens as a psychiatrist, this is a no-brainer, but harm reduction in some circles can be controversial, but it shouldn't be, because we know when we have things like syringe exchange programs and other harm reduction policies, making sure that there's access to naloxone, we simply save lives. And so that was our fifth recommendation. And of course, the sixth recommendation was, and I'll say that again because it's so important that we monitor and evaluate programs.
It's interesting. Everybody that I've worked with at the AMA really emphasizes that sixth goal. And I have to say, it's been the toughest to achieve. So for our audience out there, if there are any experienced or even wannabe researchers who are looking for topics, we need more people to look and study these programs. There's a lot out there, figure out what works and what doesn't, and then replicate what does work. Dr.
Programs
Mukkamala.
and policies, Joel, because again, we'll get a law on the books and no one ever goes back. And that's tough too. So I would put out that call if anyone is endeavoring to evaluate policies, because, I've heard this so often on a lot of policies, not just related to opioid use disorder, that, it's 20 years and people wonder, what did we get what we wanted, or maybe that wasn't such a good idea. And so maybe it was a good idea at the time, right? But this epidemic has evolved, medical care evolves. So it's always important to do that piece.
Spoken like someone who's been in the trenches. As an insurance commissioner, I can tell you that there's one thing to pass a law, it's another to get the insurance companies and others to follow those laws. Dr. Mukkamala, you can see you had big shoes to fill here. That was a really good overview of where the task force started. How has the crisis evolved? And can you tell me what the current term for it is? I keep getting confused here as we evolve and what's the exact crisis we're in now, but it's definitely evolved a lot. Tell us how it's evolved and what's happened in some of those areas that Dr. Harris just covered.
Yep, no, you're absolutely right. And Patrice did a great job of sort of laying the environment that existed when the AMA went down this road to do this work. I guess when I think about the word evolve, I think about it as a positive thing. And what's happened with substance use disorder and the nature of pain care and those that suffer with the substance use disorder, I'm not convinced that's an evolution. In fact, I might even say that maybe it's devolved, and the target has moved at a minimum. And initially, the focus was on, as Patrice mentioned, the medical source of opioids. Right, most people at that time were getting opioids through the medical system. Right, they came in for a procedure and they got a prescription for opioids, and so much of the attention across the country back then, as it relates to pain and how we and our patients deal with it, was on the source of those opioids, right? I mean, I remember vividly when I started my practice here in Flint, going into a patient's room and seeing a board on the wall, and it would have sort of who was taking care of them that day, what their diagnosis was, and then smiley faces to frowning faces to talk about pain being the fifth vital sign. And it was in every patient's room. And we were so focused on controlling pain, and the medical care was honed in on that vital sign and taking care of it. And so a lot of people will say that the natural consequence of that is, we've learned about appropriate prescribing of opioids. So that initial focus on the medical system sort of raising our level of understanding had good consequences, like PDMPs, the prescription drug monitoring programs, where now we can check. Every EHR that I've seen has a way to sort of easily check and check the state database about what somebody's risk is if I give them this prescription for an opioid of an overdose. And the number of checks of that PDMP in the past 6 or 7 years alone has gone from something like 50 to 60 million to 1.1 billion queries of that sort of system, right? And so the medical system, we as physicians, have now incorporated at least that check of what somebody's risk is into our workflow. But despite the consequences of all that, despite a 40% reduction or greater than 40% reduction in opioid prescribing in the past decade, more people than ever have died from an opioid overdose. So this is what I would say about devolving, right? So more than 100,000 people now have died from an opioid overdose. And this is driven not by the things that are coming from our prescription pad, but by things like illicit fentanyl, right? The fact that there's rainbow fentanyl now, right? That's not being dispensed by a pharmacy. That's not coming from my prescription pad. I've never written a prescription for rainbow fentanyl. And yet that's what's killing people. And so the epidemic has changed and the task force has changed with it. So to your question, from recommendations like register for the PDMP, expand naloxone use, encouraging safe disposal of prescription medications and bringing back your prescriptions that you haven't used for safe disposal instead of having them sit in the medicine cabinet for somebody to use them at home that they weren't prescribed for, all of which are still very important. But those recommendations weren't going to suffice when the target moved. And so now we have recommendations like removing barriers to care for patients with pain. Prior authorization, as Patrice alluded to, these barriers to do the right thing, whether that's the prior authorization to get them a non-opioid alternative care for their pain, step therapy. Don't make a physician and a patient have to go through something that they know doesn't work in order to get to what does work, right? Dosage caps, arbitrary sort of numbers on what can be prescribed. And then again, the X waiver removal, so making it easier to get people trained to take care of their patients with pain. And then barriers to mental illness and care for people that are incarcerated. So whether that's jail or prison, don't deny medications to people that are incarcerated. We would never tell a diabetic patient in prison that, you know what, you're in prison, you can't get your insulin. So why would we tell them that they can't get their buprenorphine? It's just, so we need to sort of, move with the changing face of this epidemic so that we don't leave people behind. And don't break up families when a new parent with a substance use disorder or somebody that's about to be a new parent and has a substance use disorder, we should anticipate the consequences, and we shouldn't break up the family when treating a medical condition like this. And coverage for, as Patrice mentioned, the non-opioid pain care. There are things that people can use to control the pain that they're suffering from that don't rely on opioids. And yet it's so difficult to do the right thing that we know a patient might benefit from, but because of things like prior authorization. And then finally, I would say that the collaboration that we need to see, it's not something that we, within the halls of a hospital or within the halls of our exam room, can solve. This has left that arena, right? This is now in our communities because of the illicit nature of this. And we need to raise that level of understanding, whether it's insurance commissioners, whether it's attorneys general, whether that's law enforcement. It's pretty much every one of those people needs to work together. And naloxone is great at saving lives, but there's more to harm reduction than having naloxone everywhere, right? We can save the life of that person with naloxone when they come into the emergency room or have it available at home. But to keep getting to the brink of losing that patient only to save them with naloxone isn't going to cut it, right? At some point, their luck will run out. The availability of that will not be there when they need it the most. And so that's why, the consequences of the initial focus, patients with pain have suffered as well, right? As with that 40% reduction in opioids, now we have patients that have been left out in the cold because of that. And so we need to be able to remember, in addition to dealing with substance use disorder itself, how to take care of our patients in pain. I mean, we need to make doctors more comfortable treating them like they are now for other mental illness. I mean, I remember a generation ago, it would be unusual to have an internal medicine physician prescribe an antidepressant for somebody with depression. Now it's almost routine because that comfort level has risen. And that's where we need to get with the management of substance use disorder. There's a lot of discomfort. Here in Flint, it's interesting. We're getting buprenorphine training for our medical students, right? Because they're interested, and this is how we're going to change the trajectory of this condition. But those medical students then go to physicians' offices where they're doing rotations, and the physician that's supervising them isn't comfortable because they haven't had that training. That's what we need to fix. And so, again, we need others with us to remove these barriers like prior authorization and improve the level of understanding of substance use disorder to continue to move from a devolution to an evolution.
Great answer. The numbers on pain medication and kind of the the use of registries and so forth, pretty impressive changes there. I mean, a lot of lawmakers don't seem to have caught up yet. They're still focused there. And what I heard a lot in your answer was compassionate medicine. And then that makes me think, we have a lot of stigma out there still. Why is it that people can't be compassionate about this kind of illness in the same way they're compassionate about so many other illnesses?
Yeah, I mean, I think it's just raising that level of understanding. We have a long way to go between where we are now, where we're treating a diabetic patient and a patient with a substance use disorder so differently, right? That visceral reaction that we have sometimes when people see somebody that comes in with ketoacidosis, right, in dire straits with diabetes, no one has any thoughts about anything except saving that patient's life and getting them out of that crisis. But you change that narrative just a little bit, and now that patient comes in blue, not from diabetic ketoacidosis and a coma from that, but instead now from an overdose and a substance use disorder. There's all sorts of thoughts that go through people's minds that shouldn't, right? That's the stigma. And when we get past that, where both blue patients are treated the same way with the same sort of visceral compassion, then we've truly progressed.
Your lips to God's ear. Dr. Harris, I want to come back to you now on, some of the hard truths here. I mean, we've done a lot of good work over the last 10 years, the AMA, other people, but still the crisis is getting the best of us. Frankly, the mortality rates are going up, as Dr. Mukkamala said. Young people now leading the mortality tables, black and brown people. There's deep inequity in the way this problem hits people. What are those trends, and what do you have to offer here as to what we can do about some of these inequities here and just the overall mortality levels that we just can't seem to get control of?
Very important conversation. And I go back to at the very beginning, and we had formed this task force. And so the AMA and me as representing the AMA, began to be invited to a lot of forums and a lot of seminars, on this topic. And I remember probably for the first maybe even year or so, it might be me as a lone physician on the panel, and most of the other panelists were law enforcement. Now, maybe that's a bit of hyperbolic and biased memory there, but there's no question that our response to opioids heretofore, when it came to Black and brown people, was incarceration. If you go back to the 60s and the 70s, when the opioid that most Black and brown people were using, they weren't the only ones, by the way, but Black and brown people were using heroin, and our collective response in this country was incarceration, a totally criminal justice focus. And you mentioned truth telling, and I am that. And so again, when candidly middle class, upper middle class, white families began to be impacted by this, then the conversation shifted. And I've always said, as a psychiatrist, as a physician, I'm glad the conversation shifted, right? I'm glad the focus was elevated regarding treatment, and that treatment worked. But I say that because I think it's always important not to forget our past on this and how we responded in the past again, when what people saw, it wasn't true, it wasn't the reality, but what people saw, perhaps what we saw in the news, what people talked about, were Black and brown people, and our response was incarceration. And then let's talk about pain. Another experience that I had, again, participating in panels, and I was actually backstage waiting to go on, and someone who I believe was well-meaning and well-intended said, isn't it a good thing that, and again, as Bobby said, we were focused on opioids from physicians and from prescriptions. And this person said to me, again, well-meaning and I'm sure well-intended, said to me, well, it's probably, isn't it a good thing that we underprescribed? I'm using my words now. She didn't say these exact words. We underprescribed opioids for Black people because now they are sort of a part of this new issue around opioid overdose. And again, I just said, let's think about that. Let's unpack what you just said. Because what you just said meant that Black people were undertreated for pain. And actually, that's not okay. But we know that there are lots of myths around among medical professionals. And this is getting better. So I'm going, earlier. We've Bobby evolved maybe on this one. To where at least there's heightened awareness that, in fact, no, Black people don't have thicker skin. Black people don't have a higher tolerance for pain. And when a Black male or female comes into the emergency department for opioids, the default should not be that this person is simply drug seeking. Although if I can just, just go off on a brief tangent, even that, and this gets to stigma, and we've had some recommendations around that in conversation, because when people came in, listen, if you're coming in, you go to see Dr. Mukkamala, and you're trying to get him to prescribe you an opioid for the sole purpose of diverting it and selling it, that's one thing. But if you're coming in to see Dr. Mukkamala or me, and you have a substance use disorder, I want to, it's still an issue, it's still a concern. I want to separate that, because that's the other, I think, problem that we're getting better at, is we just lumped everybody into one big category. And that's another important component when we talk about equity. We need the data, and we need to disaggregate the data by sex, by race, by age, by ethnicity. And so we have this cauldron here of issues that certainly has led to, as you know, this increased rate of overdose, often these days due to illicit fentanyl, and often with unsuspecting, and this, folks who think they are getting a regular oxycodone, and they don't know that it's laced with fentanyl or carfentanil. And so we need to disaggregate the data so that we can have that data inform our solutions. And one more point regarding special populations, you mentioned our youth. And Bobby mentioned rainbow fentanyl. And we've just seen story after story. Just, I think, a couple of weeks in the New York Times, there was a story on 3 bright, young professionals who, again, and not going to pass judgments, another conversation, but they called up to just take one pill. And it was laced with fentanyl or carfentanil, and they died. And so we have to make sure that we are, have an eye attuned toward these special populations. Again, the Black and Brown community and the issues surrounding past and present, but also our younger folks. As a child psychiatrist, again, when I hear these stories, I mean, all of these stories are tragic, but more and more young people, children even, dying. We need to make sure we have our eyes on all aspects of this epidemic.
Thank you for that. Dr. Mukkamala, pick up on one of the areas that we haven't talked as much about here. I call my doctor and say, I've got a cardiology problem, or my kid has a cardiology problem. They never say, we don't have any cardiologists in the network, or they're all full now, you'll have to wait a couple months. They get paid a lot of money, but they're in the networks. Then they come to, these mental health issues and these substance use disorder issues, and you call them up and they're like, well, we can't get anybody that will come into our network. You'll have to wait a while and so forth. What can we do to kind of have the capacity to treat people who need treatment?
Yeah, no, it's such a critical question, Joel. And what can be done is, one, we need to make people aware of this dichotomy. The fact that, if I need a hip replacement, and I go to any hospital in my community, I can get on the list for that procedure and get it done within weeks, right? But if I have a substance use disorder, it can be months, if ever. As Patrice already mentioned, the horrible statistics about identifying somebody that needs that sort of treatment and actually getting them that treatment. That is a huge barrier. Right? And there's multiple causes of that. And that's exactly what we need to call out. And coverage is one of those main ones, right? So that mental health parity that is there in a document, but not in actuality, not in real life, is a big barrier to that. Right. So even if there's the availability of it, to actually get somebody engaged and get it compensated for the people that are providing that care is a barrier. And so, yes, it definitely needs attention to sort of get rid of this double standard that we have between the list of medical conditions that any one of us knows that we can get treated, and then this particular one that has such a barrier. Again, we need to raise the level of understanding about the nature of pain and pain care. I mean, as an example, when the CDC guideline came out as an initial response to awareness of the opioid epidemic, that language created an environment of hard numeric thresholds, cutoffs, as far as how much opioid a patient should get or could get. And it took years to correct that error. And we're still dealing with its consequences and aftermath today. And as it relates to substance use disorder care, when again, I mentioned when we treat a patient with ketoacidosis from diabetes, we don't hesitate to do it, but nothing other than their care and saving their life is on our minds. Yet, if that same patient, you switch the diagnosis, there are all of these barriers. And so that's really what needs to change. It's a culture change that needs to happen.
So I haven't done my job as I should here. You guys have had longer answers, but they've been really good answers. So now we got to go to a lightning round to conclude the interviews, and they may be the three most important questions for our audience. I'm going to ask each of you in sequence. Proudest moment in this work, greatest challenge ahead of us in this work, and why do you do this work? So I'll start with you, Dr. Harris. What's your proudest moment in this work?
Well, Joe, if I could, I would take a little liberty here and say it's not just been one moment. It was a series of moments, but I'm most proud of the fact that through the collective, again, this task force, the AMA, and all of our partners, the other national specialty societies, state medical associations, we changed the narrative. When we first started, it's all doctors' faults and everything would be okay if they would just stop prescribing or decrease the number of opioid prescriptions. And also the fact that there was a criminal justice focus. And so I believe that over the course of time, we have changed that narrative. And I am most proud of the fact that, again, we broadened the conversation and changed that narrative.
Dr. Mukkamala, your proudest moment.
Yeah, I would say that, from where we began with this, right? I mean, I alluded to the statistic earlier, 60 million checks of a prescription drug monitoring program by physicians in this country to now 1 billion checks of that same sort of system, right? So physicians are doing their part. We've reduced our opioid prescribing by more than 40%, right? So we have taken this issue on and we've changed the way that we're taking care of our patients. When I started my practice, we would routinely write Tylenol with codeine elixir for every patient that we did a tonsillectomy on. It was just sort of automatic. We did it because we were trained to do that way. Now we pause. We realize, that's not necessary for everybody. We check the PDMP. We've changed as physicians the way that we practice. And that's what I'm most proud of. But I'm also proud that we didn't just change what we're supposed to do and say, okay, our job's done, right? We changed how we practice, and we're leading the conversation through interactions like this so that others can also be brought up to speed and we can change together, because it's more than just what happens in our exam rooms and operating rooms and hospital floors.
Thank you. So second question, what is the greatest challenge we face in the drug overdose epidemic, Dr. Harris? And maybe a little bit at the end about how can we turn that to an opportunity?
So I'm quite worried about access to treatment. I was in 2014 and I am now. And so certainly physicians have stepped up and we received the training required. And we are working and making progress, but we still have policies where insurers, and here's again a policy opportunity, is making sure there's network adequacy in the states, and the states can make sure that there is appropriate adherence to the policy laws. So biggest challenge, access to treatment, but therein lies opportunity for policy change.
Thank you. Dr. Mukkamala, what's the biggest challenge and how do you turn it to opportunity?
I think Patrice was very eloquent in describing sort of the policies that make this challenging, that shouldn't be making it challenging. It's challenging enough that we have rainbow fentanyl out there. We have illicit drug use that's sort of driving the overdoses that we're seeing now, and the unpredictability of what's in these things that people are taking, and then the nature of their substance use disorder that's difficult to treat. On top of all that, we have barriers to doing the right thing, as Patrice alluded to. So, those are the two biggest challenges. What's coming at us from the outside that isn't within the sort of our medical sphere of influence, and then within our medical sphere of influence, the barriers to do the right thing. Both are big challenges.
So you both obviously had many choices in your medical careers. Why did you do the work in this area? Why did you choose to work in this area? Dr. Harris.
Well, I wanted to become a physician because of Marcus Welby. And so the younger folks in the audience will have to Google that. But, I saw that physicians early on when I was in junior high school, physicians had a platform and an opportunity to improve the lives, not only of the patients who were in our exam rooms, our offices, and our clinics, but also on a broader level. And so when I ran for election for president of the AMA, I talked about the fact that physicians run towards problems. And so this is a problem that we have to run towards. And certainly we have done that at the AMA, and we have done that through the task force that both Bobby and I have had the privilege of chairing.
I've not heard Marcus Welby's name brought up for a long time, I will say. Dr. Mukkamala, why do you do the work that you do?
I do it just because I think we have a responsibility to our communities to improve the care of our community, right? When we saw what COVID was doing in our communities, right? We sounded the alarm. We said, this is not just the flu. And we raised people's awareness of it. And it was difficult, when it wasn't, when people didn't know people that passed away from COVID, there was some sort of denying it. And then now that it's got to be 1 million deaths, everybody knows somebody that's passed from COVID. We shouldn't have to get to that point as it relates to substance use disorder, right? We need to raise that level of conversation. I do a little social experiment where I ride the city bus here in Flint periodically. And in front of me was a guy that was, could easily have afforded to have a car. You could just tell by the way he was dressed. And yet he was riding the city bus. And it turns out he was going to a counseling session for a substance use disorder. And this is in my own community. When we look around and we see how many people substance use disorder has touched in our own communities in the same way that COVID has, then we don't have a choice but to help our communities rise past this epidemic.
Thank you both for representing well what the AMA has done to address this crisis and what work remains ahead of us. One of the people that we interviewed said that the reason I do this work is because too many people are dying. And if the things you've said today would be listened to by the policymakers and the regulatory officials, maybe we'd have fewer people dying. So thank you again for all the work that you and the AMA do.
Thanks, Joe.
Thanks.